here's the beginning problem. We have diaphragm, which has an opening in it. Which diaphragm is two domes. Okay. Lungs are up here, heart's up here. Okay. This has an opening that was too big, kind of a teardrop shape. If you were to look up at it, that's what you'd see. Here's probably the most important thing. I'm going to use a very different color so you can tell it's different. The surface of everything in the abdomen has a thin membrane over it called the peritoneum. So with a hernia, we have this membrane which covers the diaphragm and covers the stomach, creates a hernia sac. This was clear up behind your heart. Okay. Coming down inside that, this is at the esophageal hiatus, which is the opening through which the esophagus comes. Stomach should be here, and I can't tell you exactly how it came in, but the esophagus is not covered with peritoneum. So at some point it comes in here, and this is probably enlarged over a period of years, unknown how many years. The stomach is jammed up here. She couldn't swallow properly. This may slide in and out depending on activity, position, various things. But a lot of times when she's eating, it's not sitting in the right place. It doesn't empty well. Things reflux. She could have pneumonia issues. She was actually doing okay, but it seemed like it was getting worse and worse and worse.
Acid reflux is getting extremely bad.
So you can't fix acid reflux if the stomach's up. This is a negative pressure environment. It's being collapsed or sucked out, basically, because this is for ventilation, it's not for digestion. And this is positive pressure, so pressure tends to push things out. So when we went in to correct the position of the stomach, okay, laparoscopically, try to keep it minimal incisions, which is standard approach nowadays. So we did that on Friday. The good thing is this came down easily. So bloop, bloop, bloop. Let me just, we'll move on with our same picture. When I say it came down easily, that means the stomach came down and the esophagus came down. With a little traction, gentle traction. There it is. We still have this hernia sac, which means as long as that's there, it's gonna continue as a space. So if you repair this opening, if you leave this space, this never really closes down, and there's a lot more risk of it coming back. So you take out the hernia sac.
Okay, that explains why you were saying that you were thinking it could be a possibility.
Yeah, so this was easy. This took literally, getting all the instruments in place. We decided to use a robot on it, had a nice camera and a little more dexterity. But the actual getting a hold of the stomach, pulling it down was like minutes. There's no cutting or cautery or anything. But now, as soon as you let go, it goes. So, and I do have a couple still pictures of this opening, with nothing, everything up there, and then maybe halfway pulled out. So we have to we do a little bit of freeing up any attachments that are normal. The hernia sac is circumferential, so as more and more of it comes out, it kind of gets jumbled up around the top of the stomach, which can be that's really the hardest part of the case. get this out of the way. So in the process of doing that, we didn't see any problems. Sometimes you see problems. I've had holes in the stomach. It happens. As long as you recognize you repair it. We didn't have any, uh-oh, gotta fix that kind of incidences. So nobody wants complications. I don't want her to be in the ICU. This is no benefit to me to have her to go through a miserable day and a scary surgery and this whole rigmarole. So just in case anybody was suspicious about, this is a good thing,
Yeah.
this is not a good thing. What was I gonna say? So the injury, an injury to an adjacent organ is always a part of surgical risk. Definitely the ones you don't recognize are the ones that are scariest. If you recognize them, most any you can repair it. You can cauterize it, you can stitch it, you can take a section out if you have to. But if there's an injury you don't see, like I said, the roller coaster starts and you may not ever get it to stop. So that's much worse. So I don't know if there was an injury that occurred during the procedure that I didn't see. I kind of am amazed because, let's see, how should I, I don't want to jump way ahead. Maybe I shouldn't. So anyway, we took the sac out. We'll go back to this. We'll stick with our original plan. So this was resected. So what you want to do with that, the goal is that tissues that are here, that should be here, the lung area will now collapse down and kind of over time glue themselves together gently, and there's less chance of this reoccurring. Okay. Then we closed. We do this. So during the course of this, we want to get to this opening of the diaphragm and stitch it up. And the way that's done is we had a very big more open and better seen than a lot of other surgeries like this that I've done. A big opening around the back side of the esophagus, right here at the G junction. So we put this little rubber loop around it temporarily, put a stitch through it, and so that can be held out of the way. So, I'll go ahead and draw maybe what that looks like. This all the way around the esophagus so that we can achieve this kind of exposure. An instrument holding this back out of the way. My assistant. And then we have this opening, which I partially erased, which we want to close. We want to tighten this up, but not too tight. So we get that, and it kind of looks like that. With some stitches. Okay. And then this is removed. So let's remove it. So we were almost done at that point. This is the first procedure still, okay? The second, don't worry, the second procedure won't take this long to describe. I still was concerned about stuff sliding back through there, although there was nothing really pulling it back in. But you have to realize this is a positive pressure. Stuff wants to go in every direction. And that's one of the directions it can go. So to kind of stabilize it, take this part of the stomach, this floppy part, the fundus, and now it's not pulled over that way, and actually you're not going to be able to see this, and then fold it, just very slightly fold it up to here. So there's kind of a fold in it with a couple of stitches to the diaphragm. Okay? That's it. No NG tube. We didn't have any tubes in at that point. Now, I don't know what happened. I can't say. This is what we could throw out guesses. So, one guess, was there an injury we didn't see? We talked about that one. Can't say. No, I don't know how to prove there was or wasn't. It's possible. I think it's still possible. There's a condition called Boerhaave. Now, this stitch looks like it's in the esophagus, but the esophagus is on the other side of the diaphragm, so we didn't accidentally catch the esophagus. There are situations where somebody will throw up so vigorously that it'll actually rupture the esophagus, which is in exactly this position. So far, I haven't really been digging through records or anything, but we've talked to a few people that were involved. Vomiting wasn't a big, I haven't heard that it was a big issue. I never got a phone call about it, I didn't see it, I saw her in the recovery room. She was pretty comfortable, she was waking up slowly, kind of, okay, as expected. I know later she had quite a bit of discomfort. Was there more stuff going on that they didn't bother or mention to me? Would it have made any difference from, you know, guns come in and rescued her sooner? I don't know. It's all speculation at this point. It's a pretty fragile structure. So why did, a good question, why did it take so long to figure out what was going on? Well, I can't show you the x-rays. I can, but not in this room. So we could pick up pretty quickly the next day that things were not going as expected. So we get a chest x-ray. We see a big air bubble here. Like, we thought we took that out. Is that stomach? Did it slip back? My fear, but I haven't seen that happen like day one, but I was worried enough to put a couple extra stitches in. Maybe, and well, I can't tell if that's just, I was up there, and we see fluid here in the lung. Well, not in the lung, but next to the lung. There's a space here in the chest. More than expected. She's, so I couldn't tell if this was odd looking from surgery or if there was actually a movement of the stomach up into that space. So we said, okay, we could CAT scan, or we can do, maybe we just have her drink a little contrast. So we said, let's have her drink a little contrast, and we'll redo the chest x-ray. We'll get a lateral chest x-ray, look from the side. So we see fluid, we see the contrast here. And a big bubble. And I'm like, okay. Is that under the diaphragm? You can't really see a diaphragm on x-ray, so we don't know if the diaphragm's, is the diaphragm here, or is the diaphragm here? Believe it or not, it's hard to make this decision, this difference. And I'm like, well, you know, if the diaphragm's up here, then my stomach's okay. Then the treatment is an NG tube, decompress the stomach, hopefully the pain will get better. That's an easy fix, let everything calm down. So we put an NG tube in, which I did myself, which was pretty easy to do. I'm running out of colors. Which we do. Let's go with green. So NG tube, and we got a third x-ray. So you make sure the tube's in the right place. NG looks like this. Went right past this. Right. Interesting. Went and talked to radiology. Meantime, we had to change radiologists in the middle of the day because they covered like 12-hour shifts. So I got another opinion on all the previous x-rays. And our second radiologist said, oh boy, I can't answer your questions unless I get a CAT scan. I can't tell from the chest x-rays what's going on. As it turned out, they never couldn't tell what was going on. But so we got a CAT scan, and this space, which I think had more contrast in it at that point, looked like it was not contained. had little areas where the contrast seemed to be drifting out, but they still thought it was stomach. It wasn't stomach. They thought it was stomach. So the NG was actually fine. It went right straight through. It stayed in the stomach. It stayed in all the right places, which was good. So we didn't poke a hole in anything with an NG tube, which can happen. Everything's got risks.
Because you were concerned that it didn't go down.
She was looking so bad, and we were clear that, okay, something that we didn't want to happen has happened, but we're not really sure what it is. We got to go to the operating room. She was stuck to do whatever it takes to get the problem solved. You don't want to mess around laparoscopically, and there's still a problem. Especially if you're so unstable, you can't take a second insult. You've got to fix it to the best of your ability. So to sacrifice the good old-fashioned incision is a small price to pay to surviving, right? Mm-hmm. We know those heal and people get better, and not a big deal. So I'm glad we did that, and there was no question. And I had my partner come in at some point early in the case, just so we had at least two brains working on what's the solution. It wasn't that complicated. So we open up the belly, it looks perfect. You know, first glance, stomach's right where I left it, stitches look good. Little areas where we were somewhat concerned about stomach being traumatized looked fine, nothing leaking. So I took down my stitches. Which were kind of holding up this little flap, right? Oh, she's so unstable going to sleep. And I know there's fluid here. The concern is there any way that one of the things that can cause instability rapidly is if there's an air leak, pneumothorax, which there wasn't, but you know. And I knew I had fluid here, and I went and talked to them. I'm probably going to drain it just to cover all the bases. So before we were asleep, well, she was asleep. Before we started the abdominal part, I put in chest tubes. Small incision into the pleural space. So the lung is here, but it's not, the tube doesn't go in the lung, it goes in the space. There's a space. It's a tiny space. It's normally this much of a space. If you get a pneumo, it can be a big space. If it's fluid, it's just kind of like this fluid around this little potential space between the chest wall and the lung. That's where these are. So there's a couple of chest tubes. We get all this drainage out and then it stops. No air, nothing under pressure or tension. So, because one of the things we were dissecting up here, we're right next to the lung. But, so you know, I used to worry about it a lot, but the fact is I've never seen an injury to the lung, in spite of how close, millimeter, not even a millimeter apart. So chest tubes are in. We take this down. We'll go backwards now. This repair is fine. Stomach didn't move. So stomach temporarily goes right back to where it was. And we get some drainage out of this space, which is good. I drew my peritoneum again. This was not. So diaphragm was where it belonged. So we ruled out this now. We've drained this fluid and this stuff, which is contrast, came out of the chest. So what they were thinking was stomach was not stomach. It was the space where the hernia had been, but it had contrast in it. Where the contrast, she drank the contrast. So
anything that she was eating.
Yeah, well, we hadn't fed her, except we gave her contrast, so we let her have some clear liquids to drink.
She had Jello,
which she really wasn't interested in.
Well, she had Jello too.
Yeah. Mm-hmm. So, but clear liquids is NG to go by. That's where it came from. Now, why we weren't, don't know. Things got moved around for sure. Did she throw up? Did we put a hole in it that big and not recognize it? So did it happen during or after? I don't know.
My concern is that, well, for her right now, it's not what happened to it, you know, because it doesn't matter.
So do you want to know how I repaired it?
Yeah, do you want to know how you repaired it?
Okay. So this was the repair we decided. The good news is, so she has something, so this might come up. She has something, this causes, you're getting a lot of anatomy and physiology, but that helps you kind of understand what we're dealing with, doctor side of things. So in the chest, there are basically 3 spaces. Okay. The pleural spaces, and then the mediastinum. In the middle, mediastinum. Mediastinum is the middle space. It contains the heart and the esophagus. And in this case, it used to contain her stomach. So she has, as a result of this, mediastinitis, inflammation. Itis is inflammation. You know, you have bursitis or arthritis. Get it? Mediastinitis. It's just a suffix that means inflammation. So this is the area. These fluid out here was not this stuff spilling through. It's a reaction to what's going on in here. So the fact that we don't see tons and tons of fluid coming out of the chest still is a good sign. This has been, the insult has currently, hopefully permanently, but currently it's controlled. So mediastinitis. You're going to be experts in mediastinitis. It's a bad problem. First 20, if you can identify and treat it in 24 hours, very, very good. If you show up after a week of it, not so good. So I know I don't want to say, oh, we're in a good shape. I'm not saying that, but I mean, it's we could be in worse shape. So the repair, so pretty straightforward. We have pretty healthy looking tissue. We don't have tons and tons of contamination in spite of her reaction to it. We close this in 2 layers. So the first layer is a full thickness running absorbable layer, stitches. Then we kind of fold the esophagus over it again, kind of like a little tube, to cover up the first layer. And the second layer is done interrupted, permanent stitches. They're silk. So that's, and then we have an NG tube in position, but we actually exchanged because we wanted it to go nasally because it might need to be there for a while because the anesthesia switched out and put in an oral one, did some things. So we wanted to be able to guide it in so it wouldn't go through our new repair. I mean, you know, damage it. And so her NG, at least when we left the OR, was not enough. And I actually put one more stitch here just to tighten it up just a bit. It just looked like it needed it. It's not super tight. And then we further divided 2 blood vessels. These are called short gastrics because they go off this side of the stomach. Maybe we took 2 of those. Usually when I do a anti-reflux, I come all the way up this side to really mobilize it. And then we did this same flap, but slightly different. Now we made it a true, it's called a thou patch. I didn't invent any of this, otherwise it would be a Smith patch. It's a thou patch. So we take the outside of the stomach, intact, still a functioning part of the stomach, turn it over, and then stitch it on top of the repair. So you have healthy, well-vascularized tissue. In case anything leaks, you hopefully cause a very tiny little reaction that stimulates kind of like a glue to form. So it's actually now flips back over. Last time it was sutured to the diaphragm. Now I'm more interested in the esophagus. So almost done. I don't think I'll have much more after So this all gets covered up again, except this time it's right onto the esophagus. And behind it, remember we have this repair. And maybe to the best of my ability, I put on the back wall permanent stitches again. Stitch, 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 stitch. 4 quadrants to hold that down. And then stitch, stitch to the diaphragm again. Now, besides that, we have a tube up in the mediastinum. That's the blue one. I don't have a blue pen. It's got a blue stripe on it. Comes out here. To me, that's the most important one right now. You know, I can irrigate through it. I haven't irrigated into it. It's only been draining stuff out. I have another drain, which we used the old laparoscopy incisions. We didn't make any new incisions. We have a drain out here in case anything leaks around this area. If we can get it out and nothing's pooling, that's usually going to be a controlled leak. It's much better than an uncontrolled leak. Right now we have no leaks, so that's what we would, that's our best thing. Oh, that's the brown. And then downstream, because they're like, well, okay, here we have an esophageal injury. When's the patient going to be able to eat? Could be soon, could be we have a leak, we have to wait, we don't want to make the leak worse. We can give IV nutrition, but it's not as good for the body as anything into the intestinal tract. But this is kind of a don't go through here for a while. So downstream, we bring this up to the abdominal wall. This is the direction. So a little tube in the bowel, out the skin. This has to have a special tunnel made so it doesn't leak. And then stitches